Well, my area of special interest is in neuromuscular disease. I first started seeing patients when I did a fellowship with Hans Zellweger back in 1967 in his neuromuscular clinic, and one of the driving forces for that was a neighbor of mine in my hometown who had Duchenne dystrophy. And my first few efforts at science were to help identify carriers of that disease. For many years, we didn't make much progress in that, especially in therapy. But in the last decade, probably a little less than that even, there has been spectacular changes in advances in technology, and particularly with relation to genetic technology. Our first attempts at gene therapy with Duchenne dystrophy were made difficult because the gene is very large, over 2 million base pairs, the largest known human gene. And if you're going to introduce a normal copy of that gene, there is no virus that can take that amount of DNA in. So the development of the CRISPR technology has allowed us to develop much smaller pieces of DNA that can be delivered to the muscle and to cells in general. This doesn't apply just to muscle, but muscle is the issue that I've dealt with. And this technology allows us to take a cassette of normal DNA or even modifying RNA into a virus and to deliver it to the muscle fibers that way. And that has made it possible to actually do effective gene therapy in some of these patients. So it turns out now that we know that Duchenne is a fairly heterogeneous genetic entity, because there are in-frame deletions and out-of-frame deletions, and there are stop codons and various things like that. And so a single technique is probably not going to solve all of the issues. The first drug to come along was a stop codon read-through. It was a nonsense oligonucleotide, which allowed us to force the, instead of stopping at a stop codon, it would read through that frame and produce a dystrophin, which was not a normal dystrophin, but which did function better than none. The next was the exon skipping, and if you have an in-frame deletion, it's amenable to exon skipping. And we've now seen a half dozen probably exon skipping techniques for different exons that are missing come into practice. And we don't know yet how effective they will be, but certainly they will be more effective than we've had treatment in the past. And up to this point, we've been treating the disease with steroids, prednisone or prednisone-like drugs, which have worked as, my opinion is they work as membrane stabilizers and have slowed the process of the muscle degeneration that occurs in that disease. But it doesn't stop it, and it doesn't reverse it as is the potential for genetic therapy, gene therapy, if you will. We have also recently developed the possibility of treating another common neuromuscular disease in pediatrics, spinal muscular atrophy, with two possibilities. The drug that's first available is is a nonsense oligonucleotide that changes the splicing of the SMN2 gene, which allows it to produce functional protein. Because this is a relatively small mutation compared to Duchenne, and it's a relatively small gene, this gene will lend itself probably to gene therapy with a cassette of normal genetic material introduced by a virus. Adeno-associated virus is the one that's being used now, but those are on the horizon. Both treatments for Duchenne as well as for spinal muscular atrophy at present are quite expensive, and that's with the development of these new drugs in a increasing number of diseases. We will have to have meaningful conversations with drug companies and with insurance companies and with government oversight agencies to try to develop some way to fund these therapies and the development of these drugs. That's a problem we haven't directly addressed yet, although we're beginning to recognize that need.